Welcome to the deep dive. Today we're zeroing in on something that might seem like a tiny detail in root canal treatment, but honestly it has a massive impact on whether that treatment succeeds in the long run. It's all about precisely where the cleaning and filling of the root canal should end what we call the apical limit.
Exactly. Yeah, think of it like this. If you're building a fence, maybe to protect your garden, the most important part is making sure there are no gaps at the bottom.
Right.
With root canals, that bottom is the apex of the root. And getting the treatment just right at this specific point is, well, it's crucial for preventing future problems.
And to really get why this precise endpoint is so critical, we're diving into a pretty fascinating study from 1998.
Rakucci and Langland.
Yes, Rakucci and Langland. This research team took a very close look, under a microscope, at what actually happens in the tissues when root canal procedures are done at different levels. They compared treatments that stopped short of the natural end of the root canal with those that went beyond it. And they looked at this in both vital teeth, healthy ones, and necrotic or infected teeth.
Right. The basic question they were tackling was, what are the tissue reactions when we don't quite reach that natural endpoint, or conversely, when we go past it? And why does this matter so much for the long-term health of the tooth?
Understanding their findings gives us this real kind of behind-the-scenes look at what makes root canal treatment work. It helps us understand why dentists aim for a very specific endpoint and what really contributes to a good outcome. Hopefully this deep dive will give you some valuable clarity on, well, this really important aspect of dental care. Okay, so let's unpack this. This idea of paying such close attention to the very tip of the root. Where did that even come from? It can't have always been the main focus, right?
You're right. It wasn't always fully appreciated. This study actually points way back to a researcher named Davis in 1922. He was really one of the first to highlight that careful attention to these tissues right at the root tip was essential for successful root canal therapy.
So it wasn't just about cleaning out the main part of the tooth. The very end mattered just as much, even back then.
Precisely. And Davis's insight wasn't just like a one-off idea. It was actually backed up by quite a bit of research over the following decades.
Okay.
You had studies by people like Hatton, Blaney, Neigert, Usby in the 30s and 40s, and several others right up into the late 1960s. They all generally agreed that what happens at the apex is critical.
Right.
Interestingly, some of those earlier studies, especially when the nerve inside the tooth was still alive, even suggested that maybe only a partial removal of the pulp was the best way to go sometimes.
Oh, really?
Yeah, so the understanding has definitely evolved. But all these findings really underscored how sensitive and, important those apical tissues are. And this brings us to the concept of the apical constriction as the ideal target for treatment.
The apical constriction, okay, that's the really narrowest part of the root canal, isn't it? Right near the very end of the root, like a bottleneck.
Exactly. That's a good way to put it, a bottleneck. And a lot of our detailed understanding of this key area comes from the extensive work of Langland. He studied it for many, many years, starting back in 1957 and continuing right into the mid-90s.
Wow.
He, along with others like Lin, make some really important observations. They found that even when there was significant infection around the root tip, what we call a periapical lesion.
The dark spot on the x-ray.
Exactly. Surprisingly, live pulp tissue with its nerves and tiny blood vessels often remained in that very apical part of the main root canal.
Wow. Okay. Even with a big infection outside the tooth, there could still be living tissue right at the tip inside. That's quite surprising.
It really is. And it leads to a very logical conclusion for treatment. If vital tissue can persist there, then even if we see an infection on the x-ray, the goal should be to clean and fill the canal right up to that apical constriction, that natural narrowing.
Okay.
Which is usually just a tiny bit short of the absolute end of the root that you see on an x-ray.
So the end point we see on an x-ray isn't necessarily the biological end of the canal. It's more about finding that internal narrowing.
That's a really, really key point to grasp. Yes. And Langland's later research around 1995 reinforced this even further. He basically concluded that even in cases where the pulp inside the tooth was completely dead and bacteria had moved into the tissues around the root, the apical constriction was still the safest and most appropriate limit for our root canal treatment. It's the furthest point inside the root canal we should aim for.
Okay, that makes a lot of sense. So this study by Rakucci and Langland in 98 was really looking to see if this whole idea held up, wasn't it? To see what actually happens in the tissues when you respect this boundary versus when you go beyond it. How did they actually do the study?
Well, they looked at 49 roots from 41 human teeth, and these teeth had, a range of conditions. Some had healthy living pulp, others had dead pulp, and some already had those infections around the root tip, the periapical lesions we mentioned.
Right.
Was critical about the study design is that the root canal procedures performed on these teeth were intentionally stopped either just short of that apical constriction or extended beyond it.
So they were deliberately comparing these two different endpoints in real human teeth.
Exactly. They then used a common technique, lateral condensation with cold gutta percha being that rubber-like filling material.
Yeah, I know that one.
Along with the zinc oxide eugenol sealer, which helps fill in tiny gaps. Then, after different periods of time, and this is interesting, ranging from just 18 days up to over 10 years.
10 years, wow.
Yeah, 10 years and 8 months, actually. They took tiny tissue samples from the apex of the root and the surrounding tissues. These samples were then looked at really closely under a microscope as histological analysis to see exactly what changes had happened at a cellular level.
Wow. Following some cases for over a decade gives you incredible insight into the long-term effects. Okay, so let's get into it. What did they find when the procedures were kept within the canal, stopping short of that apical constriction? What did the tissues show?
Okay, so in cases where they only cleaned the canals and maybe put in medications like calcium hydroxide or quercetin, but didn't actually fill the canal yet.
Right.
They saw some interesting things. If there was already a radiolucency, that dark spot on the X-ray showing infection, the tissue samples often showed both ongoing chronic inflammation and flare-ups of acute inflammation. So the infection was definitely still active.
So just cleaning and medicating wasn't enough by itself in those infected cases.
It suggests that while those steps are really important, that final seal is also crucial. Definitely. And in cases where there wasn't an initial radiolucency, so maybe a vital tooth, they observed varying degrees of longer-term sort of low-level inflammation in the remaining vital pulp tissue right at the apex, and sometimes even in the tissues surrounding the root itself. So it hints that even just working inside the canal can have some kind of impact on those delicate tissues just beyond.
That's interesting. It suggests there's a real connection between what you do inside and the tissues right outside.
It does seem that way. Now, when they looked at cases where the canals were actually filled or obturated and were considered clinically successful by the dentist.
Okay, the ones that looked good.
Yeah, the ones that look good on follow-up. They often still found some chronic inflammatory cells present in that remaining bit of vital pulp tissue at the apex.
Still, even in the successful ones.
Yeah. However, in some of these successful cases, they also saw healthy periodontal ligament. That's the tissue that attaches the tooth root to the bone. So kind of a mixed picture sometimes.
So even when the treatments seem to work clinically at a microscopic level, there might still be some signs of the body, reacting.
That's a key nuance, yes. And in other cases with shorter follow-up times that were also clinically successful, they still noted varying degrees of inflammation in the apical and periapical tissues.
Okay.
What was also interesting is that in some of these clinically successful cases, they found calcifications, like little hard deposits forming in the apical part of the canal. These narrowed the canal down, but they never completely blocked it off, and they often occurred right alongside that low-level inflammation we mentioned.
Calcifications in a tooth that was considered a success. That sounds a bit contradictory. Is that good or bad?
It's complicated. It's something we'll definitely circle back to because it highlights a complexity in how we interpret healing. But then, they also looked at the cases that were clearly classified as failures. What did they see there?
Well, I'd have to guess much more severe inflammation, right? And probably signs of ongoing infection.
Exactly. Spot on. In the failure cases, they consistently observed strong, severe inflammatory reactions in the periapical tissues. And crucially, they were able to identify bacteria within the debris left inside the canal and even hiding within those tiny channels in the root structure, the dentinal tubules. This really points the finger at persistent bacterial infection as a major reason for treatment failure.
So getting rid of all those bacteria and their, byproducts is absolutely critical then.
Absolutely. And the study highlighted one particularly striking example. They called it Case 24. They actually found food debris like vegetable material.
No way.
Yes, infected with bacteria lodged in the apical part of the canal, which had somehow been left open to the mouth.
Yikes.
Yeah, it really emphasizes the critical importance of getting a complete seal to prevent things getting back in.
definitely. Okay, now what about the other side of the coin? When they went beyond that apical constriction, overfilling, what were the consequences then?
Overfilling, yeah, that sounds like it would almost certainly cause problems, doesn't it? Pushing material where it shouldn't be.
Seems logical.
And the study's findings strongly support that idea. In all 6 cases where the sealer and/or the gutta-percha filling material were pushed beyond that natural narrowing at the apex, either into the tissues surrounding the root or into those little side canals, they consistently observed severe inflammatory reactions in the periapical tissues. They found tissue death, necrosis, and definite inflammation right next to where the filling materials have been extruded.
So it's not just about potentially pushing bacteria out. The filling materials themselves can really irritate the tissues if they end up in the wrong place?
Precisely. That's a key finding. Interestingly, though, they did note that pain wasn't always present in these overfilled cases. Yeah, and in a couple of instances, cases 15 and 17, they even saw a reduction in the size of a pre-existing infection despite the overfill.
That is surprising. How could an infection get smaller if you've got irritating filling material pushed out there?
It suggests the body's response is complex, maybe unpredictable sometimes. Perhaps eliminating the main source of infection within the main canal still had a net beneficial effect, even though the overfill created a new, different source of irritation.
Okay.
However, the consistent finding of significant inflammation with overfilling is definitely a major takeaway.
Got it.
Now, what about those cases where previous infections looked like they had healed based on the x-rays? What did they find when they examined the tissues microscopically?
You'd hope to see a completely healthy regenerated tissue, I guess.
Well, in 8 such cases, even though the dark spot on the x-rays seemed to have resolved, the histological sections still showed the presence of a vital pulp stump, that little bit of nerve and blood vessel tissue still hanging on right at the apex.
So just because it looks healed on an x-ray doesn't necessarily mean everything is completely resolved at the tissue level?
Wow.
Yeah.
That's a really important distinction for you, the listener,
to
understand. Yes. Now, the study also brought up some key discussion points based on all these observations. What were some of the broader implications they drew?
Well, one thing they consistently found, it seems, was that even with really careful cleaning and shaping of the root canals, tiny remnants of pulp tissue and those little bits of tooth dust, dentin chips, often mixed in with the sealer, were basically always present at various levels inside the canals. Sometimes this debris even got pushed out beyond the apex into the surrounding tissues.
Yeah, this really reinforces that no matter how meticulous we try to be, our cleaning techniques aren't perfect. They just aren't. It underscores the importance of trying to minimize the amount of debris produced and, crucially, keeping it confined within the canal system. And this leads us right back to this principle of minimal wound size. The study really emphasizes that stopping our treatment at the apical constriction respects this principle. You're creating the smallest possible wound at the end of the root.
Okay.
And generally, a smaller wound just tends to heal better with fewer complications.
That makes intuitive sense. Less disruption, smoother recovery. Now, the study also touched on something called the patency technique, which I know is a bit of a debated topic among dentists.
Yes, the patency technique. It gained prominence around 1989, and it involves intentionally passing a very fine instrument just slightly beyond the apical constriction during the cleaning process.
Why? What's the idea there?
The idea behind it is to ensure that the very end of the canal remains clear or patent-free of any packed debris. However, Ricucci and Langland, based on their detailed histological findings and just basic principles of wound healing, they strongly questioned this approach.
They didn't agree with it.
No. They argued that intentionally pushing an instrument beyond that natural narrowing actually damages undisturbed, potentially healthy tissue and essentially creates a larger wound.
So instead of keeping things cleaner, you might actually be causing more trauma and potentially hindering the healing process.
That's exactly their interpretation. They even refer back to earlier work by Nygaard-Usby in vital pulp cases, which suggested leaving this apical tissue undisturbed led to better outcomes. And Langland's own work in necrotic cases showed similar observations that undisturbed, uninflamed tissue could still be present right at the end. They even point out that this kind of contradicts some common teachings in American endodontics, that advocate for using this patency technique.
So it sounds like they're really advocating for a more gentle, less invasive approach right at that critical endpoint, the very tip of the root.
Precisely. They also discussed the solutions used for cleaning and medicating the canals. They highlighted using 1% sodium hypochlorite, that's a diluted bleach solution,
Right.
because it's effective at killing bacteria, but also has relatively low toxicity to the surrounding tissues compared to stronger concentrations. They also talked about calcium hydroxide, a common medication put inside the canal between appointments.
Yeah, why is that used?
Well, they noted its high pH, which is also great for killing bacteria, and its ability to provide a long-lasting effect with a low risk of irritating those periapical tissues. They also mentioned it might help neutralize harmful bacterial toxins like LPS.
Okay.
So it's not just about physically flushing things out, it's also using chemistry to help create a more favorable environment for healing down there.
So it's a combination approach, mechanical cleaning, and chemical disinfection for the best results.
Exactly. They also addressed something called the cemento-dentinal junction, the CDJ. For a long time, this was thought by some to be a key landmark. It's where the outer layer of the root, the cementum, meets the inner tooth structure, the dentin, and some believe that should be the target for ending root canal treatment.
Yeah.
But what did this study have to say about the CDJ?
They basically said it's irrelevant for healing. That seems like a pretty strong statement.
It is pretty strong. Langland himself pointed out back in 1995 that the location of this junction is actually highly variable, even within a single root canal. It can differ by several millimeters.
Wow.
And, most importantly, it's impossible to accurately identify clinically while you're doing a root canal procedure. You just can't tell where it is.
So aiming for something you can't reliably locate doesn't seem like a very sound strategy, does it?
Not at all. And this brings us to the real challenge, figuring out exactly where that apical constriction is located. The study mentions it can be almost 4 millimeters away from the absolute anatomical end of the root, based on other research.
Of millimeters. That's a lot in that tiny space.
It is. And it makes relying on a fixed distance from the radiographic apex, like that old idea of always stopping exactly 1 millimeter short on the X-ray, very unreliable. And probably a frequent cause of accidentally overfilling. They specifically mentioned cases where the root tip is angled. A 1 millimeter short fill on the X-ray might actually be going way beyond the constriction on one side of the root. So a simple one-size-fits-all approach based purely on a flat X-ray just isn't biologically accurate.
So it really requires a more nuanced understanding of the root's 3D anatomy than just looking at that 2D image.
Absolutely. And they emphasized again that overfilling, even if there are no bacteria being pushed out, still causes tissue damage, inflammation, and a foreign body reaction to the sealer and gutta-percha materials themselves.
Right.
It's like the body reacting to, a splinter, something that just shouldn't be there.
So it's not just about avoiding pushing infection out. The materials themselves are irritants if they go beyond that natural boundary.
Precisely. They also discuss those little side branches and networks you sometimes see at the very end of the root lateral canals and apical ramifications. The study points out that these are generally so small and complex that they simply cannot be effectively cleaned or disinfected, not mechanically with instruments, nor chemically with our irrigating solutions.
So even if you see them filled with sealer material on an X-ray.
Right, if it looks like sealer squirted into them.
It doesn't mean they've actually been cleaned.
Exactly. It just means the sealer has been pushed into them, likely along with whatever debris or bacteria were already there.
And that's not necessarily a sign of successful treatment, then?
No, not really. Because that sealer material, now in direct contact with the vital tissues within these tiny side canals, will cause localized inflammation and a foreign body reaction, just like overfilling the main canal does, only maybe on a smaller scale.
Okay.
So a radiographically impressive fill, showing lots of these little branches filled, sometimes called puffs, doesn't automatically equal excellent biological treatment. The key remains the tight seal at the main apical constriction.
It's about getting that main seal right, not necessarily filling every tiny offshoot you might see.
Exactly. And they reiterated that even if bacteria have managed to extend slightly beyond the apical foramen, the actual opening at the very tip, the apical constriction still remains the limit of our instrumentation and filling.
Why is that?
Because the body's own immune system, its defenses, will usually deal with any remaining necrotic tissue or bacteria outside the canal once the source of the infection inside the canal has been eliminated and sealed off.
Oh, okay.
Our primary focus has to be on eradicating the bacteria within the root canal system itself.
So our main job is to clean and seal the inside of the tooth effectively, and then kind of trust the body to handle anything minor that might be just outside that.
Precisely. They explain that failures in root canal treatment are usually due to persistent bacterial products, or maybe reestablishment of bacteria getting back into the canal system, perhaps through a leaky filling later on. Healing indicates that the bacteria have been successfully eliminated. A recurring infection or a lesion that never quite heals suggests that bacteria have either come back or that maybe some harmful bacterial byproducts haven't been fully neutralized or removed.
Okay. And what about those hard deposits, the apical calcifications they saw in some of the clinically successful cases? Were those a sign of the body healing itself, like forming a natural barrier?
This is where this study provides a really important clarification. While these calcifications might sometimes be seen in cases that look clinically successful, when they looked at them under the microscope, they actually indicated the presence of dying or dead tissue, not healthy healing.
Oh.
They are not, according to this study, a sign of healthy, vital tissue forming a true physiological closure. The authors really emphasize that if you just look at a limited view under the microscope, a single section, you might mistakenly think these calcifications represent complete healing, a nice, solid barrier. However, by looking at serial sections, essentially slicing the tissue into many, many thin layers and examining them all sequentially, they could see that this wasn't the case. There were often still gaps, inflammation, or non-vital tissue present.
So it might look like a solid wall, but it's maybe more like, I don't know, scar tissue than actual healthy tissue regrowth.
That's a pretty good analogy, yeah. A more complex picture than just seeing a hard barrier form at the end.
Okay. So bringing it all together then, what's the main message we should take away from this deep dive into the Riccucci and Langland study?
Well, the big takeaway, according to their very detailed research, is that the best and most predictable outcomes in root canal treatment are achieved when you have thorough cleaning and a dense filling that stops precisely at the apical constriction, that natural narrow point near the end of the root.
Right at that boundary.
Right at that boundary. And conversely, the worst outcomes, or at least the most consistently inflamed outcomes, were associated with procedures that went beyond that crucial apical limit.
Which makes perfect sense, given all the tissue damage, the inflammatory reactions, and the potential for foreign body reactions they observed with overfilling.
It really does tie it all together. So as you think about this incredibly small, almost microscopic area at the very end of a tooth root, it becomes clear that this seemingly insignificant detail, the exact point where the treatment ends, has really profound biological consequences for how well that tooth will heal and ultimately its long-term health.
It really does make you wonder, doesn't it? What other seemingly tiny details, maybe in completely different fields, might have surprisingly large and important impacts that we don't always fully appreciate? It definitely encourages you to, well, dig deeper and maybe question established practices sometimes. Thanks for taking that deep dive with us.